Wait, is the audio projected here too? Silverberg, did you go to Grand Army yesterday? Did you go to Grand Army yesterday? What's up? I will. Alright, good morning everybody. I think we should get started. So good morning everybody. God bless. Welcome to another great conference. It's a pretty exciting Wednesday. We have an awesome lineup including EM/CCM, which is my favorite. Sorry, I'm biased. And a fabulous faculty lecture by Dr. G. So the schedule's a little bit tight and the transitions are going to be tight, so hopefully we're able to get up and chat and use the restroom fairly efficiently today, but we're emergency physicians and we can adapt to anything. So hope everyone has a great week coming up, and let's get going on conference. Dr. G.
Okay. Wow, I hope you still applaud me at the end of this. Okay, so we're going to talk about the emergency usage of antibiotics. All right, so why am I going to waste an hour of your time talking about antibiotics, right? So they're important. They reduce suffering. They save lives. They're the second most common ED drugs after analgesics. They can be toxic in many different ways. So, Lao Tzu said, try to avoid conflict, but when you're forced into mortal combat, choose the right weapon and wield it well. Right? So the same is true of antibiotics. You have someone who is really sick, you have to know how to pick the right antibiotic and how to use it. So what are our goals and objectives here? We're going to learn about the bugs, that's the enemy. We're going to learn about the drugs, the weapons, and we're going to learn about the pugs, which means a pugilist, the guys fighting the infection. Right? So it's all about the bugs, drugs, and the pugs. Right? And then we're going to put it all together, how to choose the right antibiotic. All right, so we have many different kinds of bugs. We have bacteria, we have viruses, we have protozoa, we have fungi, we have worms. They're all out to get us. Right? So we're going to concentrate, though, today on bacteria. And bacteria, for my purposes, I like to divide them up. And I divide them up often into gram-positives, gram-negatives, anaerobes, and atypicals. And the reason I do that is when I was training back in the day, a lot of drugs were more narrow, and they only covered one of these spectrums. Now a lot of these drugs cover a lot of these things. But I still like to think of it in this way. All right, so how do you identify what you're going to kill? Right? How do you identify the bugs? Well, one way is to do cultures and sensitivities. But you ain't going to get them back in the ED. It might help you if the patient doesn't respond to your treatment, and then they come back later, and you now have a culture. That doesn't happen often. It may help the floor if they're sick and you admit them. Okay? But most of the time, you're on your own, guys. Okay? So what about gram stains, right? Sure, we have a lot of time on our hands. Like yesterday at SUNY Downstate, I was drinking cappuccino and, you know, had a lot of time to do a gram stain if the state would let me. They won't even let me gram stain there. But gram stains are only useful for a couple of things, and that's in fluids that should be sterile that are now acutely infected. So CSF, a gram stain, can help you, and also Joint fluid, that you should get. But often, you don't have a gram stain. So, first question, what do bacteria and realtors in Brooklyn have in common? First question, anybody?
Location.
It's all about location, location, location. Right? I'm not going to be able to see, you should have said closer. All right? So it's all about location, location, location. And if you can figure out where the infection is, a lot of germs like specific places, right? So, meningococcus likes to live in the penthouse, right? Pneumococcus likes to live 3/4 of the way up. Gynecoccus likes to live in the basement, right? So it's all about location, location. If you can figure out where the infection is, it may help you narrow where you pick the antibiotics from, right? And then sometimes you have a patient who is so sick, and there may be more than one source, and you're not sure of the source, or you just say to yourself, hey, just blast him. Hit him with Vanco and Zosyn, right? VZ, or ZV, zoster varicella virus, whatever. So, now, how do you find out, though, where and who are these bugs, right? And it all starts, again, as I told you, medical school with the history, right? They're coughing. They have dysuria. They have severe abdominal pain. They have a terrible looking rash, right? However, it's not always that clear cut, right? Especially at the extreme of ages, things can present atypically, right, in the newborns and in the older people, and you may not always have a classic history, right? And then there's the physical, right? You should look for clues. CVA tenderness. We had somebody yesterday who, you know, they sent over from Fast Track, and when we pounded on her back, she had severe CVA tenderness and she had pylo, right? Or you find an acute abdomen when you do your exam. So the physical is important. And then labs and imaging, okay, especially x-rays and to find pneumonias, and urines to find pylo and urosepsis and UTIs, and, you know, CTs to find pus all over the belly. Okay, so let's just do some interaction here, right? So first, let's start with the skin. So what organisms like to live in the superficial skin and infect it? What are the two most common organisms? Staph and strep, including MRSA for staph, right? Because MRSA is kind of special, it's a little more resistant. Kate, I'm sorry. I don't want to throw it overhand at you. Nettie, you can have one. All right. How about a deeper infection, right? How about something in the foot, like a diabetic foot, right? What do you got to worry about there? Okay, so still staph and strep, but now you may have anaerobes. It's really deep, like a nasty, stinking decubitus ulcer or a nasty diabetic foot. You may have gram-negatives, right? Although recent studies show that Pseudomonas and diabetic foot aren't as common as we thought, and probably should only cover for them when they're really sick or they really stink, right, and they're septic. But you got to cover them much more broadly when you have really a deep skin infection. Okay? And then bites. So what do you worry about if someone gets bit? Right? Besides becoming a zombie or something. My favorite show. Right? Walking Dead. So,
Fusobacterium.
what do you worry about? Name some. Huh?
Fusobacterium.
All right, so anaerobes. Weird anaerobes that live in the mouth can do that. Staph and strep on the skin, you may break the skin and they may get in as well, right? But definitely those anaerobes. And what particularly, let's say I have, all right, let's say I have a human bite, what specific anaerobe is there in human bites that you got to cover for. That's actually pretty sensitive to penicillins and its derivative. Human bite. I'm sorry? Iconella? Yeah, Iconella corrodens. Yeah. Schnitzer. Should I just supposed to catch that?
Schnitzel.
I don't know. All right. Then also anaerobes in the mouth, right? And some of whom have become resistant, like Bacteroides, have become resistant to plain penicillin. Right? We'll talk about what drugs to use. But, all right, so how about in dog bites? What do you got to worry about in dog bites? Anything special? Pasturella, and along with sometimes staph, again because you're breaking the skin, but Pasturella. And if you don't have a spleen, some weird infection called DF2, which we really see. But who said Pasturella? Okay. How about cats? How about cats? What about them? They tend to get more infections in dogs or less infections in dogs? All right, they tend to get more, right? Because number one, they're puncture wounds, so they're hard to clean. And number two, the Pasturella in cats seems to be a more invasive one, right? So cats, you almost always are going to cover them. Right? Okay. All right. Now, moving right along. All right. So where do bugs live? How about in the respiratory tract? So let's talk about upper respiratory tract. Say I had a bad tonsillitis. Okay? Let's say I had a nasty tonsillitis and with big nose, exudative tonsillitis, and fever, especially I'm young, and I don't read the literature anyway, so I don't know that some people don't like to treat this organism, but I still do. So what organism would you worry about with that? Strep. Yes, strep. Right? Okay, how about I have a really bad sinusitis. It's lasting more than 10 days. It's not such an acute kind of viral. It's becoming more nasty and purulent. It's been going on for quite a while, and it's hurting me. I'm maybe getting some fever from it. Right? What organisms will cause a bacterial sinusitis? Right? Most sinusitis, when they're acute, are viral. But as they become more chronic, they're usually bacterial. And especially what organisms you got to worry about initially.
Strep pneumonia, Moraxella.
So strep, Moraxella, and Haemophilus if you haven't been vaccinated. Right? Here you go, Sally.
Yes.
Put that in your coffee and smoke it. Okay. How about if I had otitis? What organisms you worry about with otitis other than virus? What bacteria worry about with an otitis? All right, so the same. Number one would still be pneumococcus, and then more and more you might see with chronic stuff some Moraxella if they're not vaccinated Haemophilus, but especially pneumococcus there, right, for otitis media. We're not about externa. Right? How about if I was talking about externa? What two organisms most in externa? Pseudomonas, especially if you're a swimmer, right, and staph. Those are the two that will give you externa.
Oh man, my Dominicanism failed.
That was meant for Thailand. That wasn't meant for you.
Stop taking that.
And actually, I thought the Jews were better baseball players than the Dominicans. Right? We had Hank Greenberg. When was that? In 1930?
Hasn't been a good one since.
Jewish ball player. Oh, Sandy Koufax. All right. Okay. Now, how about lower? So say I have a pneumonia, right? What organism do you worry about with pneumonia? The usual ones, the usual suspects, right? So, and we're going to talk, so viruses we know, but we're going to ignore them. for now. But let's talk about bacteria. So name me the most common bacteria that would give you a CAP. We're just worried about CAP now, right? Community-acquired pneumonia. Strep pneumoniae, Haemophilus if you're not vaccinated, especially at the extreme of ages again. You can get Haemophilus, comes back a lot. And Moraxella. Okay, what else? Very important, especially in your age and a little younger. Mycoplasma, chlamydia, right? Those are the ones you want to think about. And then another atypical, besides mycoplasma and chlamydia, that acts like an atypical, even though it's a gram-negative, but acts like an atypical, and that's Legionella, right? So those would be important. Pneumococcus, Haemophilus, at the extreme of ages, Moraxella, and then the atypicals, chlamydia, mycoplasma, and Legionella, right? And sometimes, let's say if I had a flu, right? What organism, especially, there's been some recent studies that if you have a flu, what organisms likes to come in and knock you off? Staph. Okay. All right, so what kind of organisms tend to live in the urinary tract? So, okay, so gram-negatives like E. coli, the coliforms would be number one, right? And other gram-negatives a little less common, and sometimes Enterococcus and sometimes Staph. But mostly it's going to be gram-negatives and especially the coliforms, E. coli. Good. Let me see if I can get one to Wendy. I like Wendy. All right. How about the abdomen? What kind of organisms you worry about in the abdomen? So I come in with an acute abdomen, right? And now we know from some recent studies that treating acute abdomens with antibiotics initially can really help the outcome. In fact, some people advocate treating appendicitis with antibiotics initially before you take them to the OR, unless they're really crashing and have a lot of pus there. I don't advocate that, but you should give antibiotics for an acute abdomen, right? So what would you pick? What do you think? What do you think? You say it on Pitkin Avenue. What do you think? What do you think? Okay, so gram-negatives and what other kind of organisms? Anaerobes, right? The coliforms are the most common gram-negative.
Bacteroides.
And the anaerobes, Bacteroides, anaerobic and facultative strep, right? And again, that's going to help you pick your coverage later. Okay. How about the genitalia and the pelvis? We're living down now in the basement, where some of you I know like to be. Okay. So you're down in the basement. How about the external genitalia area, kind of the vaginal area, the vaginal wall, but also cervicitis? Well, what organisms would you think of there? I'm sorry?
3D strep.
Okay. All right, so actually on the outside I would worry about chlamydia. I'd worry about GC. I'd worry about BV if it's a vaginitis, bacterial vaginosis, right? And I'd worry about Candida, although it's not a bacteria. And I would worry about Trichomonas, which again is not a bacteria. But those are the things more on the outside, right? And then inside, you're right, we would worry about much deeper stuff. So besides chlamydia and GC, like when you have a bad PID or a TOA, start to worry about some anaerobes, you start to worry about some gram-negatives, right? But on the outside, mostly you want to cover GC chlamydia, especially if it's a cervicitis. And practice. Yes, give it a Wendy. She's very cute. All right. Okay, so what about the brain? Right? We're all worried about meningitis and meningoencephalitis. So what about the brain? What do you worry about with meningitis? Let's say a newborn. You've got a meningitis newborn. Because again, if you know what's covering it, you're going to know, if you know what's causing it, you're going to know what to cover it with. So what about the newborn? Right, group B strep, E. coli, right, the coliforms, and listeria, right? And if there's an encephalitis with it, you might cover herpes with it, right? If there's evidence of any focality. Very good. Okay, heart and the carditis. What do you mostly worry about? Staph, and then strep, right? Including enterococcus and strep viridans, right? And especially in drug users or with artificial valves, staph, right? Okay. Oh, nice catch there. What? You sure you're not Dominican?
Might be.
Okay. And, all right, bones and joints. What organisms you worry about? Bones and joints. What's the #1 cause of a, overall, of a septic joint and of osteomyelitis? Staph. Right. How about if I'm a sexually active woman? What's the most common cause of an infected joint? Okay. GC, right? Oh. That's how you should have reached over. All right, and then very important, unknown sepsis. What do you got to cover for? Right, so what do you think? I mean, you see this all the time. All you have to do is walk into UHB and you can smell these organisms. Right? What are unknown sepsis, right? You're not sure where it's coming from. So you want to cover your gram-positives, including staph, and now MRSA, if they're really sick, talking about their septic. And you want to cover your gram-negatives. And if you think it could be coming from the belly, or a deep skin infection, or the pelvis, then you probably should add on some anaerobic coverage. Okay? I like meta. Good catch, meta. Meta's going into infectious disease, actually, right? Next year, you give this lecture. All right. Now, for the bugs, some other questions. You want to know, are they sensitive or resistant? Especially if you could have acquired them as an inpatient or in a facility like a nursing home, right? Then they're more likely to be resistant to the usual stuff, right? Whereas outpatient, usually you'll be more sensitive to the usual stuff. And what they're sensitive to, you can go by historical data. For example, we know strep is always sensitive to what drug? Regular strep. What's it sensitive to? What's the best drug for plain strep like this? Penicillin. Okay, Dominican guy. It works. You look a little like Sammy Sosa, you know? Okay. Now, also there's data, right? National data, CDC is always giving data. You can always go on their website, right? Local data, right, from your community. The New York City Health Department is always putting stuff up. And then the hospital data, the antibiograms, right, that tells you in the hospital. And if they're done well, they should have what is outpatient acquired and what is acquired in the hospital separate. So you have an idea, right? Where is Lee Groden? God bless her, sending around those antibiograms. She's not here. You look a little like Lee Groden. Oh.
I think it's the hair.
Okay. All right. So now let's talk about the drugs. We talked about the bugs. Let's talk about the drugs. So, you know, the drug you pick has to cover the likely bugs based on often where you think the infection is coming from, right? Does it cover gram-positives? Does it cover gram-negatives? Does it cover anaerobes? Does it cover atypicals? Or does it cover a few of these classes? And you guys decide what you want to cover. Now, when you talk about drugs, there are a few questions you want to ask. How do they get in? Do I give them orally? Do I have to give them parentally, like ceftriaxone for GC, right? Drug of choice, but you got to really treat parentally. There's no oral ceftriaxone. And cefixime, which was the closest to ceftriaxone, now no longer is recommended to cover GC because of resistance. Okay? But how they get in? Do I give it IV? Can I give it PO? Right? For example, vancomycin. If I want to kill a staph infection, can I give it orally? No, it's not absorbed. But if I'm cool and I want to kill C. diff, because it's not absorbed and gets all the way down to the bottom of the GI tract, down to the basement, it'll kill what organism? C. diff. I like you, Kylie. You can have that. I like you too, Raspberry. You can have that.
This is all right.
You're not as, you're not as cute as Kylie. Okay. Now, where do they go? Very important question also, right? What do I mean by where do they go? What do you think I mean? Well, are they going to get to the area you want to treat in enough concentration to kill the bugs there? Okay? For example, will they cross the blood-brain barrier? I'm going to tell you a story. I don't like to tell stories too much, but I'm going to tell a story. As a resident, a woman came in, a woman with sickle cell, very nice woman, who had pneumonia, it looked like. And brand new drug is out. We all ran to grab it, and that was the parent drug of Ansef, right? Cephalothin. First cephalosporin out. And, we thought we were doing her a favor. We gave her that drug. She kept complaining about a headache, and we missed it. And then she's up on the ward. And then one day she suddenly went into shock and died, right? Turned out she had meningitis. Her cultures came back, and the organism she grew out of her blood was a pneumococcus, which was actually very sensitive to cephalothin, right? But the first and second generation cephalosporins, you can't trust to go through the blood-brain barrier. You need a third or a fourth generation to get through the blood-brain barrier. So what happened was, at some point early on, she had seeded her meninges with this drug, with this bacteria that was sensitive to the drug, but the drug couldn't reach it. And so when we missed the meningitis, she wound up dying because the drug couldn't reach the organisms, even though they were very sensitive at that time. Right? So you got to know where the drug is going to go. Some drugs, even fancy ones, don't go where you want it. For example, Fomyrsa, daptomycin, very expensive, very guarded drug. Not a good drug for pneumonia. Doesn't get into the lungs well. So you have to know that. And how do they work? For example, some drugs are cytal. They kill the germs, boom, like that, like the lactam drugs, right? They mess up your cell wall, and boom, you burst if you're a bacteria, right? But if you're an atypical bacteria or a typical organism that doesn't need a cell wall, you can throw all the penicillin and all the cephalosporins and all the other drugs that kill through cell wall, you can throw them away because you don't have any cell wall to be killed with. Right? You can't kill mycoplasma with a beta-lactam. You can't kill chlamydia with a beta-lactam. They have no cell walls. Right? In addition, some drugs are just static. They help slow the infection so your white cells can come and eat them up. But if you're having neutropenia, you may not have white cells because you've been on chemo to come and eat them up. And a static drug may not work. Right? Or you have an infection where white cells can't get in, like bad endocarditis. Also then cytal drugs work much better. Right? All right, and then how do they get out? What do I mean by that? What do you got to think about when you're picking a drug about how they get out? Right? How are they excreted and metabolized, right? If you have a drug that excreted in the kidneys and you have someone with renal failure, they're going to get into more trouble, right? They're going to get toxic. Or if it's metabolized in the liver and they have a premature liver, they're going to be in trouble. So what is the gray baby syndrome? What's the gray baby syndrome? Chloramphenicol, right? Chloramphenicol is metabolized in the liver. Very premature infants, or young infants, you got to be careful about giving chloromethylene, and if you give it, you'd have to give a very low dose, right? So what they found was when they gave it in the usual recommended dose per kilo to these babies who had a liver that couldn't metabolize it, it wiped out their bone marrow because the levels were so high. And they had no red cells, so they looked great. So that's the gray baby syndrome, right? You look a little gray there. You can have that. Okay, bad joke. All right, now, right, so how they're excreted, how they're metabolized, you have to take that into consideration. The other thing is what kind of damage can they do? What is the toxicity, right? You want to pick a drug that kills the germs you want well, but causes the least toxicity. And we'll get back to that. And then finally, does the drug need help? What do I mean by that? We talked a lot about that last week. There were articles about it, and everybody touched on it. Well, when does a drug need help? Well, you don't even maybe need the drug if you have good health. Plus, you have an abscess, you can give all the antibiotics in the world, and it's not going to cure it. You have an abscess, you have to drain it. If it's a small abscess, then maybe all you have to do, right? Or you have pus in the belly, you got to take it out, right? You have an empyema, you have to take it out. So pus needs help, right? Okay, nobody got that one. All right, now, drug toxicity, right? So what are the ways drugs can be toxic? A lot of them can cause hypersensitivity reaction. Yesterday, I gave a young woman red man syndrome. With what drug? Vancomycin, right? Right? Penicillin, sulfur drugs, notorious. Those are the two biggest, though, to give hypersensitivity reactions, right? Stephen Johnson's, TEN, right? Anaphylaxis. Those two classes of drugs, you always got to be careful, right? Then they can cause organ toxicity. For example, gentamicin, what organ does it like to go after?
Kidneys.
Kidney. Very good. Kidney. And, right? What about vancomycin? What organ does it go after?
Kidney.
Kidney.
It's autotoxic.
Put that in your coffee and smoke it again. All right. Right? And then drug interactions, right? Sage Wiener talked a lot about drug interactions, right? Recent article, even though I use them like water. And actually the most common drug used now is what? Most common antibiotic used is what drug? Anyone knows? Azithromycin, right? #1 drug that's prescribed. And I'm probably prescribed 3/4 of those. I like your smile, guy. So, all right. So, you got to worry though. Recent article out that in people with bad heart disease or people on other drugs that causes a QT syndrome, you can get increased mortality from the macrolides because they can prolong the QT yourself. So you have to be very careful with those and with drug interactions with some of the antibiotics. And then pocketbook toxicity, right? Some drugs are very expensive. You may not be able to afford them. Right? So, very important you think about that if the patient doesn't have coverage. We're very lucky. The county is a great place, right? Pharmacy, if you don't have money, charge you $10 and give you a whole bunch of drugs, nice drugs. And, but you go other places, you go UHB. Unless you have someone really nice like Miss Marshall who's going to help you get it for free or something. You're in trouble if you don't have insurance. They're not going to give you the drugs like Kings County does, right? So you got to think of the prices, and some of these are expensive. One time I had a bad sinusitis. I was leaving the next day to the Philippines, so I didn't have time to go down and steal them from Lincoln. And I bought a second-generation cephalosporin, 1990. Well, you think things were cheaper, right? For a 10-day course of a second-generation cephalosporin, what do you think I paid? $150. Now for me that was not a big deal, right? But hey, if you're making minimum wage or you're even getting paid under the books, even making less than that, that's a big deal, right? And one word about stuff. If you have someone who does have an insurance, there's a good place to look where you might get cheaper drugs is Target. And you can get the list, and a lot of antibiotics there are very cheap. Very good place to look, and you can look at it online. Right? Okay, and then you got to worry about community toxicity. That by using the drugs too much, you may be causing resistance. Okay? And now there's a big thing called antibiotic stewardship. What do we mean by that? You're going to hear it again and again and again. Antibiotic stewardship. In fact, Dr. Lucchese was very proud that they made him an antibiotic steward for UHB. So I was hoping they'd give him like a little ship's uniform, like being, staying on the ship, and then I could bust his chops. But, right, so what we mean is you're taking care of the antibiotics. You're checking that people aren't abusing and giving, giving Avalox for a little bronchitis, or giving Cipro for a broken toenail. Okay? That's what we mean by antibiotic stewardship. So I love this cartoon. Right? Okay, very quickly, some classes of drugs. We're not trying to go through it. But penicillin and its derivatives, very important class of drugs still. Right? So what is Gernsheimer's favorite movie? Who knows my favorite movie?
The Terminator.
Right? Anybody know?
Pitch Perfect.
No.
The Terminator.
Perfect. I can't sing.
Princess Bride.
Rambo 2. Why? Because I tell you, in that class of penicillin is L-benzathine penicillin. Very old drug, ancient drug, but the drug of choice for syphilis. Right? 2.4 million of L-benzathine penicillin IM to an adult. Cures as primary, secondary, and early late. Right? Boom. Right? And in Rambo 2, Sylvester Stallone killed all the bad Russians. I'm always half Russian, so I can say that. But he killed all the bad Russians using a bow and arrow. Right? An old weapon still can be useful. Right? Okay. Cephalosporins, 4 classes now. What do you get as you go up the ladder? You get more gram-negative, including some of them have Pseudomonas. Right? For example, ceftazidime and cefepime especially gets you Pseudomonas, right? The others don't. And especially if you look even at an older drug, like you want anaerobes. Does any of the cephalosporins cover anaerobes? Yeah, cefoxitin and cefotetan. Very useful for the belly sometimes, okay? But as you go up, you go from being more a gram-positive drug to a gram-negative. Though even though Keflex is still a decent gram-negative drug for community-acquired UTIs and stuff. Okay? How about carbapens? Does anybody know a name of a carbapen we use? Yeah, the penims are actually very, very good drugs. Right? But big guns. Guns they don't want us to use much because, again, antibiotic stewardship, not getting resistance from. But the carbapens, they cover gram-positives, gram-negatives, anaerobes. They don't cover atypicals. None of these drugs do, none of the beta-lactam. And they don't cover MRSA. But for everything else, they cover. Except irtapenem doesn't cover Pseudomonas, but meropenem does. Right? And what's nice about this class of drugs now is anybody know what ESBL stands for? Anybody heard that term, ESBL?
Extended spectrum beta-lactamase.
Very important. Extended spectrum beta-lactamase. Some E. coli and some other coliforms have decided they're going to get the resistance, not with the usual beta-lactamase, but with this extended one that can wipe out other drugs that try to kill it. Right? And the one class of drugs that seems to work best, and we had a guy over at the county in fast track who went into septic shock in front of us in fast track, and he had just had a prostate biopsy and stuff and had been instrumented. And he turned out later to have an ESBL. And the drug of choice there, if you're not sure and you think it's an ESBL, is actually a pen, like Marapen. Very good for that. Better than Zosyn, better than some of the others. Okay? All right. How about a monobacterium? Anybody knows what any special monobacterium? Okay? So the monobacterium, Astrionum, right? It's the one that's really used. What kind of coverage you get with Astrionum? Get gram-negative, a pure gram-negative drug, but covers Pseudomonas. And what's nice about Astrionum, when can you especially use Astrionum instead of Zosyn? If you're allergic to penicillin, there is zero crossover between Astrionum and penicillin, right? And a great gram-negative, good Pseudomonas drug. Okay. Quinolones, right? Something we don't want to abuse because you get resistance to them very quickly. But the fluoroquinolones, very good for pneumonia. And there's some recent studies, there's a nice recent study that shows that for outpatient pneumonia, particularly in older people and people with comorbidity, that there's less mortality with using a respiratory quinolone like Avalox, Moxilactam, or Levaquin than there is with a macrolide. Again, it's for complicated outpatient. Right? And then aminoglycosides, what do they cover? Right? They're old drugs. We hate old stuff. 68. All right. They're gram-negatives. Right? Got a bad rap because they can be toxic. But they are very potent still. Gentamicin, amikacin, tobramycin. Right? And especially because their main toxicity is kidney. If you have someone who's on dialysis and you want to get gram-negative coverage, you don't want to use Zosyn, say they're allergic or something, you can give a dose of gentamicin, there's no kidneys to hurt because you're on dialysis, and it'll stay around until you dialyze it off. Right? A great gram-negative drug to use on someone on dialysis. Okay? And it covers Pseudomonas. And if you add it to some of the gram-positive drugs like Vanco, it is synergistic to kill staph with them. It won't kill gram-positives on its own, but it helps gram-positive drugs kill staph better and strep better. And that's useful, for example, with endocarditis. Right? Often we'll use a combination of Vanco and Genta and maybe add on rifampin if it's an artificial valve. Okay, then Vanco, great gram-positive drug, no gram-negative coverage. Right? Great gram-positive drug. Also can be used to kill C. diff. And is the drug of choice for most of us for MRSA. Right? Clinda, what does Clinda cover?
Everything.
So it covers gram-positives and anaerobes. It's a good anaerobic drug, but it also covers gram-positives. How about metronidazole?
Anaerobes.
So it's the best anaerobic drug probably going, but it has no real gram-positive, gram-negative coverage. Probably should not use it alone for anyone who's sick. And it's a good protozoa drug. Right? Like for trichomonas and stuff. But a great anaerobic drug. You have a belly, and you pick outpatient belly, and you pick ceftriaxone to kill the gram-negatives. You can then add to it metronidazole to kill the anaerobes. You got great belly coverage. Or you could take Cipro, which is a good gram-negative drug, add Flagyl to it. Wow, you got great belly coverage. Right? So great anaerobic drug. Chloramphenicol. You go like Meta and go overseas and you see typhoid and you see meningitis and you don't have fancy third-generation drugs or quinolones, still a good drug if you use it correctly, right? When I worked in Haiti, we always talked about CNC cola. You came in with a bad fever, you got chloroquine for malaria and you got chloramphenicol for typhoid fever. Yeah, Meta, because I like you. All right. Now, all right, macrolides, Great drugs for atypicals, right? Best drug for Legionella, this is azithromycin, right? Good drugs for mycoplasma. Tetracyclines, doxycycline, again, great drugs for atypical, and a good drug for what other thing that we like to use Bactrim for, and we like to use, Clinda for, but it's actually right behind Bactrim. Camsra, right? Very good drug for MRSA, that's community acquired, right? Bactrim, can use it for gram-negatives, but for Camsra again, community acquired methicillin resistant staph, good drug. Nitrofurandan, good drug for UTIs, except for what? Why, if you had someone, you wouldn't want to use it for a UTI for?
Upper tract. It doesn't work in the
Upper tract, you're right. Sepsis in upper tract, it only covers the bladder because it comes out in big concentration. So it's great for cystitis. You got pyelo, you have sepsis, don't use it. They'll get worse. Yes, Sally, put another
No,
one.
I'm good, thank you.
Good. All right. And then rifampin and some of the newer staph drugs are out. Rifampin you can't use by itself, but you can use it for adding on to other regimens, like for treating endocarditis from a resistant staph in an artificial valve, right? But some newer staph drugs to cover MRSA are out there. And name me one of the MRSA drugs other than Vanco. Let's say they're really allergic to Vanco. What's another drug you could use for someone with MRSA that's hospital acquired, so it's probably resistant to Bactrim and Clinda? Like linezolid, right? Linezolid can be used, daptomycin can be used, except for pneumonia. And there's some newer ones. One that you might hear about, right? There's tetracycline also. But one you might start to hear about is something called Delavance, right? And there are two new drugs out that if you give it, Delavance and Oravance, if you give them as a single injection, they last 8 days. The other one, the one with the O, which I have trouble pronouncing, lasts 10 to 14 days. You only need one dose. So if you have, and they're excellent for soft tissue infections. So if you give one dose, it covers them. So they're not too sick. You could theoretically give them one dose, send them home. Now, they're new. And my mentor always told me, never be the first to use a drug. Never be the very, very last, but never be the first. So for now, I have no experience with that drug, and I'm waiting other people to use it and see if it messes up, and then I can say, see, I told you so. Right? I like that smile. All right, so then let's talk quickly about the PUGs. So the PUGs are, how sick is the patient? Okay? If they're sick, you got to do ABCs and goal-directed therapy. Also, if they're sick, you're going to hit them with big guns, right? If it's a little infection, you don't need an elephant gun to kill a rabbit. But if they have a big infection, then you hit them with an elephant gun or a cannon, okay? And then sometimes you need to go to McDonald's to kill these things and use combo meals, right? Maybe a lot of organisms you're worried about, some resistant organisms. So you're going to go and hit them with more than one drug. And especially if there's more than one infection, especially if they're very sick and you don't want to miss anything. And sometimes also we get synergy, like between aminoglycosides and Vanco, or aminoglycosides and penicillins, okay? So there are a few reasons to use combination. For example, in sepsis, right? Because very few things hit MRSA. Often we'll use Vanco for the MRSA, and then if we think there's a gram-negative going on, we'll use Zosyn, right? So a lot of times we use combos in very sick patients. All right, and then you always got to take in consideration when you're talking about the person fighting the infection, the pug, some special things when you pick your drug. So you got to worry about the age, right? Extreme of ages may need different drugs than other ages. Are they allergic? Then you got to pick a different one. Do they have comorbidities, or they have decreased immunity? And then you got to worry about other organisms that normally you don't worry about. Are they pregnant or breastfeeding? Then you got to worry about the fetus or the neonate who's getting breastfed. And then social factors, right? For example, the guy is an IVDA, well, I better cover for staff. Oh, the guy's an alcoholic, and yeah, he doesn't have such a bad pneumonia, but he ain't going to get his drugs, and he's going to stay out on the street drinking. I'm going to admit him and give him some IV drugs at least for a couple days, right? So social factors, very, very important. All right, and again, we talked about compliance, right? So the patient must buy the drug, they must take it. So they have to afford it, they have to be able to take it easily. Good study that if you give a drug that you have to give 4 times a day versus 1 or 2 times a day, good chance you're not going to take it, right? And then, tastes bad, you're going to give something like, anyone ever taste dicloxacillin syrup? Oh my God, kids hate it. Even when they put it in like this grape thing, I once tasted it, forget it, right? All right, so real quickly, let's just talk about some drugs of choice. All right, we just, I only have 5 minutes left, right, Sally?
Yeah.
So, so how are you going to treat, let's pick a bad one. Let's pick a cellulitis, bad cellulitis, but not with pus around, but a bad cellulitis, right? What are you going to pick to treat that? You have someone who's really sick, a nasty cellulitis. What drug might you pick? They're really sick.
Cefazolin.
Okay.
Cefazolin.
So you might pick Vanco as one. If they're not too sick, and it just looks like, you know, it doesn't look like MRSA. MRSA usually have pus. You could get away with something like Ansef or Clinda, right? So again, a lot depends on how sick they are. Not too sick cellulitis, but without pus, then it probably, you know, cephalosporin or Clinda. Very sick, I would go with Vanco. Deep infection, I would add on maybe Zosyn and Vanco. VZ, varicella zoster. Okay. Now, how about pneumonia? Just to say a regular cap. We won't talk about H cap, but a regular cap. Let's say a cap that you're going to admit, but not super sick, not to the ICU. But they're a little older, they have comorbidities. Remember thinking, what drugs cause this? What am I going to cover a cap with? Okay, so ceftriaxone plus something that covers atypical, right? So how about ceftriaxone and azithromycin? Okay, I like that one.
Nice shot.
Okay. Now, how about I'm allergic? Remember, you got to think about the pug. Maybe the host has something you have to adjust. And there's more than one way to skin a cat. So you need to know more than one way to act. So I'm really allergic. I'm going to admit him, right? But I'm allergic to not only penicillins, because the crossover between penicillin and 3rd generation cephalosporin is almost 0, right? Except if they've had anaphylaxis, you may not want to take that. But this guy's allergic to cephalosporins, right? So what drug might you use? Yeah, respiratory quinolone, Avalox or Levaquin, right? Okay, how about a UTI? Simple outpatient UTI. Not febrile, dysuria, urinary frequency, what would you pick? A lot, you could pick nitrofurantoin if you want. They're not too sick, you could pick Bactrim, although there's a lot of resistance in some places. Don't pick amoxicillin, too much resistance. How about they're a little sicker? How about Pylo, but not a Pylo you're going to admit? What would you pick? Yeah, Bactrim, you know, if you're in a place that doesn't have much resistance. But what I would probably do, I would give them a shot of ceftriaxone in the ED. If they're sick, I'd admit them and wait for the culture and stuff. Meanwhile, I always send the culture when anyone's sick with a UTI. And they have Pylo. And then I would probably say if they feel better after IV fluids and a dose of ceftriaxone, I'd probably send them home on Cipro for a Pylo. That's usually my combo, C and C, colon. ceftriaxone, and Cipro. Okay. How about peritonitis? That's a good drug to pick. Let's say it's a plain peritonitis, not someone who's operated on, you know, in downstate and now comes back. But let's say it's someone who has appendicitis that ruptured. What medications you want to pick?
Sulfoxetine.
I'm sorry?
and Flagyl.
So you could pick sulfoxetine and cefotetan. We don't have them at UHB.
And Flagyl.
Okay, so a good combo would be, I like ceftriaxone and Flagyl. Nice, gram-negative ceftriaxone, nice drug. I love ceftriaxone. Great drug. And you can give Flagyl to cover that. You can give Cipro and Flagyl. You want right now the recommendation is not to use Unison for bellies. E. coli has become too resistant for it, so that's not a recommendation anymore. In some really good recent studies, they found that. But Zosyn, especially if it's inpatient stuff. You know, someone who doesn't have a virgin belly, who's been recently operated on, now comes back, right? Then you could use a big gun like Zosyn. But something like ceftriaxone and Flagyl, great. Clindamycin and ceftriaxone if you can't give Flagyl, another good combo. Just remember what's causing the infection, okay? How about for someone who seems to have a cervicitis, who's been very sexually active, right? None of you guys, you're busy studying. But, you know, someone like me, right? Running around Brooklyn wild, right? But Charlie Sheen, right? My idol. That's a shame. That is a shame. It really is a shame.
No, it's not. It's a chronic disease. He'll be fine.
It's still a shame. Would you want to have it?
No.
Okay. You're like my sister, you know? You're like an old Jewish woman. No offense.
It's fine.
Now,
Truth hurts.
okay. Now, so I think they have GC. Not complicated. Uncomplicated GC or chlamydia. But they have a cervicitis or urethritis if they're a man. Right? Discharge dysuria. What are your drugs of choice and what doses? So ceftriaxone, how are you going to give it? They're not sick. How much? 250 for everybody. That's the recommendation because GC has become more resistant, right? And how about what else you got to cover for? You got to cover for chlamydia, for urethritis or a cervicitis. So how are you going to cover with that? Gram, right? Very important to treat them like this so they don't spread it. So ceftriaxone 250, gram of azithro to kill the chlamydia, uncomplicated, you're done. Right? Okay. How about meningitis in someone my age? Right? Going on 68, I have a meningitis, not encephalitis, just a meningitis. Think it's bacterial. What are you going to cover me with?
Ampicillin.
All right, because listeria comes back, right? Anybody ever read Shakespeare here? Right? So there's in As You Like It, they talk about the 7 stages of man, right? And you start out as a baby mewing and puking in your mother's arms, and you end up as some old man mewing and puking in your wife's arms, I guess, until she throws you out of the house. But, right? So, listeria comes back. So ampicillin will cover listeria. But what else you really got to cover? You got to cover pneumococcus. And pneumococcus, right, is usually very sensitive to ceftriaxone. But here they're so sick, you can't take a chance that it might be resistant. There is a small amount of pneumococcus that is very resistant to beta-lactams, right? So until you know, you're going to give them Vanco to cover the pneumococcus, the resistant. You're going to give them ceftriaxone, will cover the usual pneumococcus, but also Haemophilus, which you got to worry about now at the older age. And it'll cover Neisseria as well, ceftriaxone. And you give them the ampicillin. So someone my age has bacterial meningitis pending the culture. Ceftriaxone, 2 grams Q12H. Big dose. Got to get into the blood-brain barrier in high concentration. Vancomycin, good dose. And a amoxicillin in very high dose. IV ampicillin, actually. And maybe steroids. Okay. Unknown sepsis, vancomycin. Okay, let's go on. So in summary, when choosing an antibiotic, you got to consider the bug, you got to consider the drug. Does it cover the bug? Does it cause not too much toxicity? Is it not going to cause resistance too much, etc.? And the host, which I like to call the pub, the guy fighting the infection, right? Price fighter, fighting the infection, right? So, in summary, you try to pick the drug that kills the bug without hurting the pub, that doesn't have much toxicity, right? And when I told my daughter that, when I was practicing, she said, "Dad, you're a poet and you don't know it." I thought that was very cute. And so, I love this one, right? For someone who's had, almost died from a MRSA infection in my neck, I like to get even, right? Any questions? And some references. She sent around the biogram. Now, in all reality, a wonderful reference, Ben Gernsheimer, is Sanford Guide to Antimicrobial Therapy. It's a good thing to have. I know Silverberg always has it, right? You have your copy probably with you, right?
My pocket.
Okay, I thought you memorized it, to have it with you in your brain, but okay. And then these all start are really great things. It's the guidelines for almost every infection I mentioned right now. You can always look them up, right? Lee gave us the antibiograms, right? And a couple other really good review articles. Now, if you want to get bored, then you can read number 6, which isn't star because it's not as good as the others and it's old. But that's my favorite article. Okay? And that's it. All right.
All right, everybody. If you've worked overnight,